All right, so we're going to warm up our patient first for about 5 minutes on the recumbent elliptical. This is going to increase the metabolic heat production to prepare the tissues for treatment, and it's also going to allow them to use their arms to assist in the cycling motion if they have pain at the ankle. And then once they're done warming up, we're going to start with our myofascial manipulation. We're going to perform effleurage in the foot, ankle, and lower leg up to the knee joint to reduce the swelling at the ankle, as there is a drainage site in the posterior knee. We're also going to perform lateral elongation of the peroneal tissue, and this will help lengthen the fascia to sustain tension, which is going to help break up those collagen restrictions and also increase the ground substance content in the joint, or not within the joint, within the connective tissue, which should improve mobility and hopefully reduce some of the pain they're having with inversion. We're also going to perform the psoas release and iliac crest technique. By compressing these muscles, it stimulates proprioceptive input, in turn reducing the tone of the muscle. Putting the tissues under sustained load, elongating them. God, pause it, I just bummed it. I just absolutely lost my train of thought. All right, so we're going to begin with a 5-minute warm-up on the recumbent elliptical, and this will increase the metabolic heat production, preparing the soft tissue for treatment, and it allows them to use their arms to assist in the cycling motion if they have pain in the ankle while on the machine. And then we're going to begin our myofascial manipulation. We're going to start with effleurage in the foot, ankle, and lower leg up to the knee joint to reduce the swelling at the ankle, as there is a drainage site in the posterior knee. We're also going to perform lateral elongation of the peroneal tissue because lengthening the fascia with sustained tension will help break any collagen restrictions and increase the ground substance content, which should potentially increase their inversion range of motion and reduce their pain when performing the motion. We're also going to do the psoas release and iliac crest techniques because providing compression to a muscle stimulates proprioceptive input, which reduces the tone. We're also going to perform the QL side bend and strum technique to elongate the QL, as well as the anterolateral fascia in the lumbar spine. And we know that by putting myofascial tissues under a sustained load, it will elongate them due to the viscoelastic properties of the connective tissue, resulting in permanent change. Then we're going to do our muscle play of the gastroc and soleus to increase the extensibility of those muscles and allow for a more efficient contraction. We're also going to do the myofascial manipulation of the hamstring to increase the ground substance content in the connective tissue, which should increase their mobility. And it's also going to improve the fiber glide and maintain that critical interfiber distance to help prevent any new crosslinks from forming. And then after that, we're going to reevaluate to see if our techniques were effective and made any real clinically significant change for the patient.
So after that reevaluation, we're going to be doing a joint manipulation to our patient's mid and forefoot. So we're going to start with a grade 2 cuboid on the navicular, and then also we're going to be doing the cuneiforms on the navicular as well. We're going to be doing this as some palliative care because for the psychological and neurophysiological benefits, to help gate our patient's pain by stimulating the type 1 and type 2 mechanoreceptors so that he is more able to weight bear. We're also going to be doing the dorsal sweep of the metatarsal heads to help with his forefoot mobility. And this will help decrease the collagen crosslinks, improve the tissue crimp, promote the fiber glide, and increase ground substance, which will all help improve his range of motion. After doing these techniques, we're going to be going through and reevaluating to see if our patient has any signs of decreased pain or anything along those lines. And then we're going to move on to a joint and myofascial elongation phase of treatment where we're going to be doing a hip flexor stretch with the leg hanging off the table. We're going to be doing a hamstring stretch with a straight leg raise, and we're going to be doing a QL stretch over the ball. We're going to hold these positions until we feel the tissue change, which shows us that we're targeting the viscous component of the viscoelastic properties of the tissue which could result in the permanent deformation and improve our patient's range of motion. After these stretches, we're going to reevaluate our patient and before we get to the neuromuscular reeducation portion of treatment.
Thank you, CJ. So, like you said, we're going to reevaluate and see if any of our treatments have affected our patient's ability to move their ankle. If aberrant motions are still noted, we're going to have him perform 4-way ankle range of motion with 3 sets of 10 repetitions in a pain-free range to help with the proper muscle recruitment to help reduce those aberrant muscles or aberrant motions. We're also going to be teaching our patient how to perform lateral weight shifting without the boot on. And we're going to be doing this into a pain-free range for 3 sets of 30 seconds as well onto the involved foot. This is going to allow the joints and the muscles to accept the body weight and help him return back to function. After this, we're going to reevaluate and see how all of the treatments and exercises have affected our patient. We are going to educate him on purchasing an even up to help with the functional leg length discrepancy that the ankle boot has been causing, leading to the low back pain potentially. We are also going to educate him on the proper fitting and cleaning of his immobilization boot and checking for any skin irritation or changes in color and any signs of neurovascular involvement such as numbness and tingling while wearing the boot. We are also going to support our treatment with a home exercise program. This is going to involve the hip flexor stretches, hamstring stretches, and QL stretches that CJ mentioned earlier, along with the lateral weight shifting and the active range of motion to help decrease the atrophy and maintain the range of motion. And that is it. Thank you so much.